Okay, I have nothing to disclose. So objectives today, by the end of the session, you should be able to identify what the local control rate is for SBRT, for pancreatic adenocarcinoma, and also know what some of the ongoing and future clinical trials will be for this. So I want to touch base here and sort of piggyback on what Dr. Lyles was discussing in terms of the ability of patients to be able to get surgery. That's sort of what we know. The patients with the best outcomes are those who are able to go on to get surgery and get R0 resections, meaning nothing's left over. So this is a meta-analysis that's sort of often cited, basically looking at a lot of trials that gave neoadjuvant therapy, and that could be chemotherapy alone or chemotherapy and radiation in these borderline and unresectable patients, patients who were initially resectable or borderline unresectable, and then looking at the outcomes. So of those patients who were initially resectable, about 2/3 of them were able to go on and get resection. Now, the reasons they may not have is because they progressed distant mets and so forth. But those patients who are borderline unresectable, only about 1/3 of them went on to get resection. And so I'm going to call attention to this number again down the road, but that's sort of what we think in terms of, as of this meta-analysis, about 1/3 of patients in the borderline or unresectable category go on to get resection. And then again, the percent who achieve an R0 resection, obviously it's higher in those who are initially resectable, but about 2/3 of those who do get resection after neoadjuvant therapy are able to get an R0 resection. And then if you are able to do that, your survival is basically the same. So if we can get these patients onto surgery, get an R0 resection, their survival is pretty much equivalent to if they were initially resectable up front. So the role of radiation is pretty controversial, because we've got a lot of trials that say there is a benefit, and we've got a lot of trials that say, no, you can just do chemotherapy alone and have equivalent outcomes. So this was a big trial that was published last year, the LAP-07 trial. Now, this is locally advanced pancreatic cancer, so these aren't initially resectable patients, but who basically got treated with gemcitabine alone, with or without erlotinib. There was no effect of erlotinib, so I'm just going to skip on that. But then we're randomized to getting either chemo-RT or continued chemotherapy. So there was no difference in the median overall survival, so no overall survival benefit to adding radiation to chemotherapy in these patients. But what I'll call your attention to is the difference in local failure. So if you got treated with chemotherapy alone, your local failure rate was about 50%, versus if you got treated with chemotherapy and radiation, it was lower to about 30%. So I'm going to take issue a little bit with what Dr. Lyles said earlier about the FOLFIRINOX having this great effect on these resections, but all those patients also got radiation. So I think radiation does contribute significantly to both local control and also the ability to achieve an R0 resection. The other difference was, after this trial was over, the length of time that patients were able to have a treatment break. So if you got treated with chemotherapy alone, they ended up basically having progression or needing further treatment after about 4 months, versus you bought an additional 2 months by doing chemotherapy and radiation before. So one concern would be toxicity between these different regimens. So the only really grade 3 or 4 toxicity difference was in terms of nausea by doing chemotherapy and radiation together, and that rate was about 6% versus 0% in the chemotherapy alone. So if we are not affecting overall survival in this locally advanced population, but we're putting them through 6 weeks of chemotherapy and radiation together, we know we're providing a local control benefit, but why would we put them through all of that treatment for the ultimate outcome to not be that different? So what people have looked at, and the first report was really now about almost 15 years ago, 13 years ago, is can we condense that radiation treatment into a shorter stereotactic focused radiation? And sort of like Dr. Chaw discussed, we've gone from CNS to lung to liver to pancreas. So basically everyone can get SBRT now, anywhere. But at least that's what we're trying to determine. So Stanford did a phase 1 dose escalation trial, basically looking at successively higher doses and the tolerance there. Now at this time, they were all given as a single fraction. So in this phase 1, they didn't have any grade 3 acute toxicity, and then no local failures in the 6 patients who were able to get the highest dose level. So then they looked at another group of patients, and basically at this point, everyone's sequencing in chemotherapy because we know that the distant risk is the highest in these patients. So these patients got gemcitabine chemotherapy and then followed by single fraction SBRT. All of these were treated with the highest dose, so that 25 gray. So they had an 81% local control rate, which is pretty good. But the problem was about half of those patients had late GI toxicity. One was a duodenal perforation, duodenal stenosis, 5 ulcers, all found within 4 to 10 months after SBRT. So they suspected that this was due to the dose that was given to these structures, duodenum and stomach. So just to sort of let you know what's involved in these treatments. So we've talked previously about liver treatment, and it's very similar. So targeting where this is, and sometimes seeing the pancreatic tumor can be difficult on imaging. So oftentimes people place fiducials to help us line them up. You do have to take into account respiratory motion, and so some people use an external monitoring device to monitor respirations. At MCI, we have CyberKnife, so that actually tracks and moves with the fiducials. Precisely outlining the tumor, and so here you can kind of see what the dose cloud is around that to focus right there, and then actually imaging the patient on the table and making sure that your clips, your fiducials are in there and you're appropriately targeting it. And then again, here's just sort of a representative plan. Right here next to it, you can see important real estate in this area. So there's duodenum, it's got contrast in this imaging, right there up against it. So we shaped that high dose region so it's just around the tumor and are avoiding a lot of the normal tissues around it. This trial, they didn't really place dose constraints on these important structures, and so we subsequently saw that there was high late toxicity because of that. So going forward, they did start placing more stringent dose constraints on there to try to shape the radiation around. This time, again, they used that 25 gray times 1 with the constraints. Freedom from local progression was 94% at a year. They had no acute grade 3 non-hematologic toxicity. And then the late GI toxicity was brought down to about 20%. One of these was grade 3 with the perforation. The others were ulcers, all found within 4 to 12 months after SBRT. So one of the things we found in treating other sites of the body is if you fractionate out the SBRT, so you give it in slightly smaller doses, but still high per fraction, into about 5 to 6 fractions, then people seem to tolerate that better. And we just know that going back decades. That's why we treat a lot of patients with 30 or 40 treatments, is because we know that fractionation, the body heals up between each fraction. So this was a multi-institutional prospective trial spearheaded by Dr. Herman at Johns Hopkins, which we found or saw earlier has a high volume of pancreas adenocarcinoma. And they had 49 patients and treated these with 33 gray and 5 fractions. Freedom from local progression at 1 year was 80%, about 80%. Median overall survival about 14 months. And then importantly, so the acute grade 3 toxicity was low, about 12%, and then the late grade 2 or higher toxicity was even lower than we had previously discussed, now at about 10%. Importantly, there was one death on this trial from acute GI bleed, and this was with the tumor that had direct extension into the duodenum. So Moffitt has treated a lot of these patients, also with fractionated radiation therapy. And so they have a retrospective review of about 160 patients. The majority of these were borderline resectable, and about 50 of them were locally advanced. So they did something we call a dose painting technique, is where you can selectively shape where your high radiation dose goes. So we know in patients who are borderline resectable that may go on to surgery, our biggest concern is being able, letting the surgeon get an R0 resection. So they selectively elevated the dose at that tumor vessel interface to try to help sterilize that area. So resection was performed in about half of the borderline resectable patients, just about 10 of the locally advanced. Median overall survival was about 19 months for borderline resectable and slightly less for locally advanced. In patients that were able to undergo resection, the median overall survival was 34 months. So again, we know that trying to help these patients get onto the resection is really what helps them have the best outcomes. In this group that did not get any surgery, the local control was about 80% here. So again, grade 3 acute or late toxicity, 7%. So that's a pretty low number compared to the prior studies. But again, there were several GI bleeds from tumors that had direct invasion to duodenum. So one thing I want to point out here, what I mentioned at the very beginning, the historical resection rate for borderline resectable with neoadjuvant therapy is about 30%. And so with SBRT and chemotherapy on this trial, about half of the patients were able to get resections. And then here's just the overall survival curves between those who were able to get surgery and the event-free survival between surgery and no. So putting all of this together, in February there was a sort of a pooled analysis of all of the studies to date, looking at what the outcomes are for doing this neoadjuvantly. So all of them together, the local regional control is about 72%. What they found is that the dose, so higher dose, and then the number of fractions, so actually treating it in 5 versus 1, were associated with better local control. And in LAP-07 trials, so where patients got treated with 6 weeks of chemotherapy and radiation, the local control rate for that arm was 68%. So this is comparable local regional control with a much shorter treatment time. Median overall survival for all of these patients treating on all of these trials was about 17 months. The acute grade 3 toxicity ranged from about 0 to 36%. Only 3 of the studies had acute toxicity greater than 10%. And then the late grade 3 or higher toxicity range was from 0 to 11%. So our current guidelines, one thing is just to keep in mind what the intent of our radiation is. So we're trying to sterilize the vessel margins to improve the likelihood of an R0 resection. We want to provide durable local control in those patients who aren't able to undergo resection. And then any patients who are having pain or bleeding, we can palliate that with external beam. So the current guidelines allow for SBRT mainly in patients with locally advanced, non-metastatic, unresectable disease. But it can also be offered in patients with borderline resectable disease or who have disease recurrence that never received prior radiation. Should be avoided in patients with direct invasion into bowel or stomach, like I said, because those patients tend to have severe GI bleeds and potentially can lead to death. So ongoing trials, searching clinicaltrials.gov last month, there were about 34 trials that listed SBRT as a component for pancreatic therapy. It was included in all aspects, so neoadjuvantly for resectable disease or borderline resectable disease, in the adjuvant setting and in unresectable disease. Most of these were phase 1 or phase 2 trials, but there were a few randomized trials. So one's a multi-institutional non-cooperative group, basically looking at FOLFIRINOX plus or minus SBRT in locally advanced. The CROSSFIRE trial, which I'll have a slide on in a second, is basically comparing the efficacy of doing IRE, so what Dr. Rahim was talking about earlier, versus SBRT. And then combination chemotherapy, the Alliance trial, with or without hypofractionated radiation. And this is in the borderline group. So the CROSSFIRE trial, and all of these trials now, because we know the main concern is systemic disease, all patients get treated with systemic chemotherapy up front. And then those patients that don't progress after that will be randomized to either SABRE, which is sort of the sexy term people try to sell SBRT on, so stereotactic ablative body radiation therapy, so SABRE or IRE, and then basically following until there's progressive disease, and then patients can cross over to the opposite treatment after that. And then the Alliance trial, which we will be opening hopefully in the near future at MCI, is treating patients with modified FOLFIRINOX, which is sort of, I think actually Spencer was alluding to this earlier. And then they'll either continue on FOLFIRINOX or they'll get either SBRT or hypofractionated radiation. I'll kind of show you the difference here. So not all centers, I talked about how difficult it can be sometimes to deliver these treatments because of targeting and having to account for respiratory motions. So not all centers have the technology to be able to do that. So this trial is allowing centers that can't necessarily do that, or maybe the anatomy is just not conducive to the really high dose, to treat a slightly larger volume with a slightly lower dose, 5 gray times 5, in place of that. So here's the cheat exam to the pre-test you got, and we'll go over that for when you get the post-test. So which of the following must be considered when treating pancreatic cancer with SBRT? So motion of the tumor with respiration, radiation dose to adjacent organs, including duodenum and stomach, and proper identification of tumor on imaging. The answer is all of the above. And which of the following is a contraindication to SBRT according to our current guidelines? So borderline resectable disease, locally advanced disease without distant mets, tumor invasion of bowel or stomach, or locally recurrent disease that's not received prior. So tumor invasion of bowel or stomach. So in summary, the management of pancreatic adenocarcinoma should be determined in a multidisciplinary setting. There's currently no established standard regimen for treatment of borderline or locally advanced unresectable disease. Given the conflicting results over the benefit of radiation in a lot of these patients, current approaches are geared towards reducing the treatment time of the radiation and limiting treatment toxicity. And finally, SBRT should be performed only in a careful target identification, motion compensation, and image guidance.